gastric acid secretion, right? And this can act through your enteric nervous system, and it will also act via your extrinsic nervous system. Responses would be both motor as well as secretory, right? Motor means it is going to increase the gastric motility. It is going to lead to the receptive relaxation of the stomach, wherein the stomach is going to accommodate whatever food you have eaten, and then it will also help in moving the food forward after certain products have been formed and the chyme has been formed. So there would be, you could say, a controlled, the controlled emptying of the stomach will occur, right? So overall, all these responses would be initiated within the gastric mucosa. It will be initiated within the stomach itself. So this is just an overview of what are the major functions of the stomach. So the stomach, of course, when you are hungry, you eat food. This is your stomach, which is saying, I am a little hungry, and there you are eating food. It is stored temporarily into the stomach, just like a reservoir stores. You could say a dam is also a form of a reservoir which is storing water in it. So here the stomach is going to store food temporarily, and then the enzymes will act on it. It is going to be digested partially, and then only it is going to move ahead. Some other functions of the stomach include that it will be mixing and churning the food. It will initiate the digestion of food. In this, it will initiate the digestion of proteins. It also secretes HCl or hydrochloric acid, the intrinsic factor pepsinogen, which helps in the digestion of proteins. Then it also secretes mucus and bicarbonate, and it releases chyme. Chyme is what flows, the semi-fluid consistency of the gastric contents which flow into the duodenum. They are known as the chyme. But then not all is too good. If there is some, you could say, there is a disruption in the functioning of the stomach, it can create a problem too, right? So how can it create a problem? It is secreting acid, it is secreting intrinsic factor, it is secreting an enzyme, it is also secreting mucus, it is secreting bicarbonate. So there can be a derangement in any of these secretions. There can be hyper or hyposecretion of these substances. So it can create a problem. And of course, there are some defense mechanisms within the stomach which again can be deranged, and they can cause problem in our stomach, right? So let's begin with a short case of Miss Rashmi Thakur, right? So I'm just, because it will give you an overall idea of why the stomach is so important for our functioning. As doctors, you'll often come across patients who are having some gastric problems, right? So this is just a thought-provoking case which I'm introducing. So here you have a patient who comes to a doctor. When you take history, now you've already started off with your clinical examinations. So now you are very well familiar with whenever a patient comes to a doctor, you start with the history taking. In the history taking, you start off with the basic things about the patient. That patient will tell you the name, the age, the gender, and the presenting complaints. Of course, you will also ask about the profession. You would ask about the personal history, the drug history, the family history. So everything is important as far as your diagnosis is concerned, right? So here a patient has come to a doctor whose name is Rashmi, 50 years old, criminal lawyer by profession, right? So I have boldened it because everything is important in history taking. She is a vegetarian. She doesn't smoke. She doesn't take alcohol. She's a total teetotaler. Again, all these things are important when you come to the diagnosis. You know that she is doesn't eat non-vegetarian food, she doesn't smoke, she doesn't drink alcohol. Everything was fine with her. She had no complaints. And then what happened? A few weeks ago, she started having a burning, gnawing abdominal pain, right? So here you have a patient who's 50 years old, female, criminal lawyer by profession, eats vegetarian food, doesn't smoke, doesn't take alcohol, and she complains. She has come to a doctor with the chief complaint of a burning or a gnawing abdominal pain. That is, it is a moderate kind of a pain which occurs in the upper middle part of the abdomen. And this has been happening with her since the last few weeks. This pain often wakes her up in the middle of the night around 1 or 2 a.m. So you generally ask what time she normally eats food and when she goes off to sleep. So she is having good habits. She usually takes her dinner at around 8 or 9 in the night, maybe 10, not later than 9:30, 10. And she is off to bed by 10 p.m., right? But this pain wakes her up in the middle of the night. Now, once it wakes her up, she, by her own trial and error methods, she's come to realize that she gets some temporary relief in this pain when she eats something, and later on she even started taking a tablet of Rantac. She did try ibuprofen, but there was no relief in pain with it, right? So no, she is an educated patient, so she is taking, she's giving you all the details, and if she's not given the details, probably the doctor has asked. And here she is telling that she gets relief by eating something or taking a Rantac tablet, but it is not relieved by normal analgesics like ibuprofen, right? So can you start guessing what this patient might be suffering from, right? So you have some pertinent points here. You know about the profession, so criminal lawyer. So maybe she is under a lot of stress, right? 50 years old, vegetarian. She might be taking in tea or coffee. So teetotaler. She has pain, which is in the upper middle part or abdomen, wakes her up in the night, gets relief by eating something or taking a Rantac tablet. Okay. So after taking a detailed history, the doctor examines her. General physical examination is normal. There is no abnormality which is detected, right? So basically what the doctor was looking in this patient was, maybe he was trying to look for the pallor also, because the intrinsic factor is released in the stomach. It can lead to pernicious anemia. So pallor would be visible, but here the doctor was not able to elicit any abnormality. So general physical examination was by and large normal. On per abdominal examination, now because she's complaining of upper abdominal pain, so the systemic examination was more and more concentrated onto the abdomen. Abhi aapka hua nahi hai, but still. So by and large in the anatomy, you must have been told about the various quadrants of the this abdomen. So these are the 9 quadrants in which the abdominal examination is usually divided into. You have the umbilical region, you have the right and the left lumbar region. Above that is the epigastric and right and left hypochondrial regions, and below that is hypogastrium and left and right iliac regions. So on per abdominal examination, epigastric tenderness is present, right? So patient complains of pain and the doctor elicits tenderness. So pain is a symptom, tenderness is a sign. Certain lab investigations were done in which I have just written the ones which are more pertinent as far as this case is concerned. So serologic tests were positive for anti-H pyloric antibodies, and a urea breath test was positive. Both of these are consistent with Helicobacter pylori infection, right? Another investigation which was done was the endoscopic examination. Upper GI endoscopy was also performed on this patient, and this is showing you how an upper endoscopy is performed. So this is a fiber optic tube which is introduced through the mouth, goes into the esophagus, goes into the stomach, and it is visualized on a monitor, right? So this is how the endoscopic visualization is done. So upper GI endoscopy was performed on this. You have upper as well as lower. So we are concentrating on the stomach part today. So upper GI. It showed the presence of a duodenal ulcer. So this is a normal endoscopic view of duodenum, where you can see that the mucosa is intact, and here you can see that there is an ulceration in the duodenal part. So endoscopic view of duodenal ulcer. So this is how on endoscopic examination the duodenum of this patient would look like, right? So you've come to the diagnosis that the patient Rashmi has duodenal ulcer because the serologic test was positive, as well as your urea breath test also showed the presence of Helicobacter pylori infection. So she was treated with amoxicillin, and she was treated with a drug by the name of omeprazole, right? So today, the learning objectives, this is just an introduction of your stomach topic. So before you go on to abnormal, you should be familiar with the normal things. So today, the learning objectives are the key topics which have come into focus are the structure and functions of stomach, the gastric glands, their secretion, the composition of gastric juice, the gastric mucosal barrier, how the what is the mechanism, phase, and regulation of the acid secretion, the gastric function test, and peptic ulcer disease. So all these topics would be covered today, right? So this is again a structural and functional divisions of some stomach. You know, it's a hollow muscular organ which can be divided into the fundus, the body, the antrum, the pyloric canal. The exit of the stomach into the small intestine is guarded by pyloric sphincter, which is a modified circular muscle layer. And the opening of the esophagus into the stomach is guarded by a lower esophageal sphincter, right? And as you can see, this mucosa is thrown into a number of folds, which are known as the rugal folds. So we are concerned with the physiology of the stomach. So I'm not going into the anatomical aspects of the stomach any further. Types of gland in stomach. There are two types of glands in stomach. You have tubular glands and you have surface mucus cells, right? So when I told you about the organization of various layers in the GIT, by and large, GIT is comprising of your 4 layers, and these are the glands which are usually present in the mucosal layer, right? So the tubular glands and the surface mucus cells. In the tubular glands, there are 2 types of tubular glands. One are the gastric or the oxyntic glands, and the second one are your pyloric glands. The gastric glands, they are located on the inside surfaces of the body and fundus. So body and fundus of the stomach is comprising 80% part of the stomach is body and fundus. So gastric glands are located in these parts. These glands, they have 3 types of cells: the mucus neck cells, which secrete the mucus, the peptic cells, also known as the chief cells, which will secrete pepsinogen, and parietal cells, which secrete the HCl, right? Parietal cells are also known as the oxyntic cells, and because HCl is the main secretion, hence these glands are also known as the oxyntic glands. Pyloric glands, they are located in the distal 20% of the stomach, that is in the antral portion of the stomach. They also contain 3 types of cells: the mucus neck cells, the peptic cells or the chief cells. But as compared to the gastric glands, the peptic cells are fewer in number. And instead of the parietal cells, the antral these pyloric glands, they contain G cells which secrete a hormone by the name of gastric. So this is just a diagram which is showing the different layers of the stomach. So you have the mucosa. In the mucosa, you have the epithelium, you have the lamina propria, muscularis mucosae, and then you have the submucosa, the externa, and the serosa. What we are concerned about is the structure of the gastric gland. Very, very important, because you can get it as draw a well-labeled diagram. It can come as a long question, or you can a part of a long question, or you can get a short note on the gastric glands itself, right? So this is showing you a gastric gland which has been taken from the body of the stomach. So here you can see that in the gastric gland, as I told you, it has three types of cells. You have the mucous neck cells, the parietal cells, and the peptic or the chief cells. Now, all these glands, they also have surface mucous cells. So surface mucous cells, they secrete viscid mucus and bicarbonate ion. This mucus is different from the mucus which is secreted by the mucous neck cells. Okay, so there are two types of mucus which are secreted in the stomach. I'll just tell you. But right now, you have two types of mucus cells also. One is the surface mucus cells in the epithelium of the glands, which secrete viscid mucus along with the bicarbonate ions. Then you have another type of mucous neck cells, which is a part of the gastric gland itself, the tubular glands itself. So in that, it is secreting your soluble mucus, which will help in the lubrication of the food contents or lubrication of the gastric contents. Second type of cells which you can see here are the parietal cells. Now this is showing you the lumen of the gastric, or this is the gastric lumen. So here you can see that the cells are opening into the lumen. On towards the luminal side, they are thrown into fold-like projections, which are known as the villi and the microvilli, to increase the surface area. This side is the basolateral side, and this side is the apical side of the cell. So parietal cells secrete HCl and they secrete intrinsic factor. Third type of cells are the peptic or the chief cells, which secrete pepsinogen. Pepsinogen is an enzyme which is secreted in the inactive. It is the inactive form of the active enzyme pepsin. So it is a protein. It will be secreted, formed and secreted by the peptic or the chief cells. And it is the process would be similar to the protein synthesis. That would be, it will be formed in the starting from the nucleus. It would be formed, translation, transcription, and then you will have, it will reach through the endoplasmic reticulum. It will go into the Golgi body, where the post-translational modifications would occur, and it would be stored in the granules, which would be known as the zymogen granules. And when the stimulus comes, they would be released by exocytosis. Another cell which you can see here is the enterochromaffin-like cell. The enterochromaffin-like cell, this is secreting histamine, right? So this is secreting another substance which is known as histamine, which again is a very potent stimulus for the gastric acid secretion. So gastric secretion or gastric juice, what is it? It is a fluid which is secreted into the stomach, mixture of secretions from surface epithelial cells as well as the gastric glands. In an adult human, the volume of gastric juice is about 1.5 to 2 liters, and it is highly acidic, having a pH of 1 to 3. Now, certain books are giving a range from 0.8 to 4. So it's okay, right? As far as you know that it is highly acidic and it is isotonic with plasma. The rate of gastric acid varies. The rate of gastric acid secretion would vary considerably among the individuals, and this is partly due to the variation in the number of parietal cells which are present in the stomach. In the unstimulated state, when the stomach is in the interdigestive period, or it is a fasting stomach, you have not eaten anything over during the night hours. So that is your basal state. When there is a gap of 8 hours to 10 hours, that is basically the basal state. In that, the rate of secretion is different as compared to the rate of secretion when you eat food. So there are two types of secretions of gastric juice which will occur. One in the basal or the unstimulated state, and another one during maximal stimulation, that is when you have ingested a meal, right? So this is known as the basal output, and this would be known as the maximal output because it contains gastric acid. So it is basal acid output and maximal acid output. Now this basal is greater at night and lowest in the morning, and maximal stimulation would of course be when there has been an ingestion of food. So composition of gastric juice, it again comprises of water, solutes and mucus. The solutes, again, there are inorganic and organic solutes. Organic, the main constituent is the hydrochloric acid. Then you have other cations which are present there in the form of sodium, potassium, magnesium. The anions are bicarbonate, sulfate and hydrogen phosphate. Organic, it contains enzymes. The most important one is pepsinogen. Then we have gastric lipase for the digestion of fats, renin, which is usually present in the infants and adults. It's not present. Don't confuse it with renin, renin, that is the renin-angiotensin system. कई बार आप लोग ये वाली spelling लिख देते हो, which is absolutely wrong. Right, so this renin is an enzyme which is present in the gastric juice. It's present in infants. It's present basically in other animals. Then you have gelatinase, urease, and lysozymes, which are also present in the gastric juice. So this is a graph which is showing you the effect of secretion rate or secretory rate on the composition of gastric juice. So here it is showing the composition of 4 ions, which are the main ions present in the gastric juice. So ionic composition of gastric juice depends upon the rate of secretion. As you can see, on the x-axis is the secretory rate, on the y-axis it is the concentration of these ions which is shown. So as the secretory rate increases, you can see the rate of secretion of hydrogen ions also increases. The concentration of hydrogen ion goes on increasing. As the secretion rate increases, the concentration of sodium ion goes on decreasing in the gastric juice. Potassium ion by and large remains at a higher level as compared to plasma, and chloride ion, you can see, is the chief anion which is present in the gastric juice. Irrespective of what the secretory rate is, its concentration remains high. So higher the secretory rate, higher is the concentration of hydrogen ions. Plasma concentration of hydrogen is this much. When parietal cell is stimulated, it can reach a concentration of 3 million times of that of plasma, right? So a hydrogen ion concentration under maximal stimulation of the parietal cell can achieve a value of 300 million times that of plasma. At lower secretory rates, hydrogen ion is decreased and sodium ion concentration is increased. I've already told you this. Potassium is always higher in gastric juice as compared to plasma, and therefore in conditions where there is prolonged vomiting, hypokalemia can occur, right? So again here, this is, you can get it as an MCQ, you can get it as explain why hypokalemia occurs in cases of prolonged vomiting. This is the reason. At all rates of secretion, chloride is the major anion of the gastric juice. So all these things I've already told you. Have you ever thought, why is it that the epithelial cells of the stomach are not destroyed by such a high acidic content of the stomach itself? Or why does the stomach not digest itself? Auto digestion stomach का क्यों नहीं होता, despite the fact that stomach has such a high acidity. It is, the pH is ranging from 0.8 to 3 or 0.8 to 4, right? Still it is not digesting itself. इसका reason है, of course, you have pepsins also which can digest, but again, they are also not digesting the stomach. So why is it that the stomach is not digested by its contents? That is, it is not digested by the gastric acid, or it is not digested by the pepsin. The answer for this is the presence of a gastric mucosal barrier. Very, very, very important topic. Okay. ये आपको वैसे भी important है और exam point से तो important है. So what is a gastric mucosal barrier? It is the property of the gastric mucosa to protect itself from autodigestion by secreted acid and pepsin. Okay. It consists of interdependent physical and chemical processes that act in concert to protect the gastric mucosa. It acts as a diffusion barrier, and the components of gastric mucosal barrier, as it says, that it consists of interdependent physical and chemical processes. So here you have physical process in the form of tight junctions. So epithelial cells, they are bound together by tight junctions. This you've already studied in your general physiology classes. The tight junctions will not allow the passage of the ions and substances across them. Second is that there is a presence of a special layer of insoluble mucus. I told you that in the stomach, two types of mucus are secreted. One is the insoluble and the second one is the soluble mucus. So there is a special layer of protective viscid gel-like insoluble mucus covering which is derived from the surface epithelial cells. Now this insoluble mucus also traps the bicarbonate ions which are secreted by the surface epithelial cells, and this also makes the mucosal layer alkaline in nature, right? So it helps to buffer the acid which is secreted by the gastric glands. Another component of gastric mucosal barrier are the trefoil peptides, which also provide resistance from autodigestion by stabilizing the mucus bicarbonate layer. So gastric mucosal barrier, it protects the stomach from autodigestion by secreted acid and pepsin. These are the components of the gastric mucosal layer. All these help to function as a diffusion barrier. ठीक है, कैसे function करता है आप ये देखो. This is showing you a normal surface epithelium, right? This is a normal surface epithelium, and this is showing a gastric gland. As you can see that it will be having the surface epithelial cells. Now just concentrate on the colors here. You can see that there is a layer which is shown here. This blue layer which is shown here is your gastric mucosal barrier, right? So this is the surface epithelium cell. This is the interstitial fluid. This is the blood. So this is the basolateral side of the surface epithelial cell. This is the apical side of the surface epithelial cell. Now when the parietal cell, it secretes hydrochloric acid, it will reach the gastric lumen. But what happens is that if there is a, you could say that there is a specialized mechanism which occurs here, that the gastric acid, it does not disrupt the mucosal layer, but it goes by a lifting action, finger-like action into the gastric lumen. So this layer remains intact, right? Now what is this layer? This is a mucus gel layer. This is a visible layer. This is insoluble. You see the pH here in the lumen. It is highly acidic, but you see the pH profile of this mucosal barrier. It is alkaline or towards the neutral side. तो ये कैसे होती है? ऐसे होती है because the surface epithelium cell, it is secreting the bicarbonate ions into this layer. बाइकार्बोनेट इसमें कहाँ से आ रहा है? बाइकार्बोनेट इसमें थ्रू द ब्लड स्ट्रीम आ रहा है, एंड देयर इज ऑन द basolateral side you have presence of a sodium bicarbonate ion, or you could say sodium bicarbonate symporter, right? So sodium bicarbonate moves here, and then it comes into the mucosal gel layer. Second thing it is secreting is, of course, the surface epithelium cell secretes is the mucus. So bicarbonate is trapped here. जो भी हाइड्रोजन आयन बैकलीक कर रहा है इसमें, तो वो क्या होगा? बाइकार्बोनेट उसको बफर कर देगा, ठीक है? तो इस वजह से क्या हुआ, क्योंकि उसने उसको बफर कर दिया, तो इसकी जो pH है will remain towards the neutral or towards the alkaline side. So hence it is protecting the gastric mucosa by damage to the by damage by the acid, ठीक है? अगर इसमें कोई भी disruption हो जाएगा तो यहाँ पर it will start damaging the mucosa, right? So this is causing a diffusion barrier, और इसी वजह से क्या हो रहा है कि pepsin also doesn't come back, or there is no back leak which occurs of the pepsin also, right? So integrity of the mucosal barrier is very important for the normal functioning of the stomach. If it is weakened, what will happen? That there could be inflammation of the gastric mucosa, which is known as gastritis. जहाँ भी itis आता है वो inflammation होता है, या वहां पर ulcer formation हो जाएगा. Ulcer formation is the break in the gastric mucosal layer. ये अभी I'll tell in detail, okay? अगर इसका balance increase हो गया, this is just showing you the balance. If the strengthening part is heavier, so the stomach remains healthy, and if this becomes heavier, there would be damage to the barrier causing ulcer or gastritis. How does secretion of mucus occur? It is secreted at a significant rate in the resting stomach. Some stimuli which increase the acid and pepsinogen secretion also increase its secretion. So mainly it's the acetylcholine which is released from the vagus nerve which causes the production or the secretion of mucus, right? So mucus, it is synthesis of core peptide. You need not go into the details of how the mucus is secreted and synthesized. It's basically that you have to remember that there are mucus cells which are present, the surface epithelium cells as well as the mucous neck cells. And this surface epithelium cells, they form a visible mucus which is a part of your gastric mucosal barrier. Right? So these are the two types of mucus which are there. You have the soluble mucus and you have the insoluble or the visible mucus. Soluble mixes with the contents of the stomach, helps to lubricate the chyme. Now when I was taking your introductory lecture, I had told you about the properties and the functions of mucus in detail, right? So soluble mucus is basically that mucus only. Insoluble mucus is the one which I have just described, which is forming a part of your gastric mucosal barrier, and it forms a sticky, viscous, alkaline gel-like coat which adheres to the surface of the stomach, entraps the bicarbonate within itself, and helps in protection of the stomach mucosa from auto-digestion. Second substance which is secreted in the gastric juice is the pepsin. Pepsin is secreted in an inactive form which is called as pepsinogen. It is secreted by the chief cells of the gastric glands, and I have already told you that it will be secreted and then it will be first synthesized and then stored in the zymogen granules, and the contents would be released by exocytosis when the stimulus comes here, right? So here you can see that the chief cell will secrete the pepsinogen by exocytosis, and this pepsinogen will be activated into its active form pepsin by removal of a peptide bond, and this activation will occur when the gastric acid is secreted, so it requires an acidic environment for activation. and this pepsin begins the digestion of dietary proteins, and it will lead to partially digested proteins. Right? They digest about 20% of the proteins in a typical meal, and they are inactivated irreversibly by the neutral pH in the duodenum. So it stays within the stomach. In the duodenum, the bicarbonate ions would be in excess, environment would be alkaline, so pepsin would stop acting. So every enzyme needs a specific environment for its action. Biochemistry people must have told you that, right? So what are the functions of pepsin? It's a proteolytic enzyme, requires a highly acidic environment, converts the dietary proteins into digested proteins, partially digested proteins, which are peptones and proteoses. Another function of pepsin is that it curdles milk. The casinogen is converted into casein in the presence of pepsin. Functions of gastric HCl. One of the functions I have already enumerated. It causes activation of pepsinogen into pepsin, provides optimum pH for the action of pepsins. Then it kills bacteria, helps in the absorption of iron and calcium, and it promotes the pancreatic, small intestinal and bile secretion. Okay. Now we come on to another important topic, and that important topic in this is the mechanism of HCl secretion. Now this mechanism of HCl secretion comes in your exams almost every year, right? So you can get it as a long question also. What is the mechanism of HCl, or describe the mechanism of HCl secretion in the stomach, right? So HCl is secreted by parietal or the oxyntic cells at the villus-like membranes of the canaliculi, which are continuous with the lumen. So here you can see this diagram. It is showing you a parietal cell. This is the gastric lumen. This is the side towards the plasma and the interstitial fluid. So this side, which is towards the blood capillary and the interstitial fluid, is your basolateral side of the cell, and this is the apical side of the cell, the parietal cell. HCl secretion means that there has to be a secretion of hydrogen ion, and there has to be a secretion of chloride ion, right? So where does this hydrogen come from, and where does this chloride come from? So this is showing you how the HCl secretion occurs. So the carbon dioxide which is present in the cell, from where will it come? It can come through the metabolic processes which are occurring within the cell. So there is lots of carbon dioxide within the cell, or it can also diffuse from the bloodstream into it. It come here and combine with water in the presence of enzyme carbonic anhydrase to form carbonic acid, which is a very unstable acid, breaks up into bicarbonate and हाइड्रोजन आयन. ठीक है, तो पहला स्टेप क्या हुआ? कार्बन डाइऑक्साइड combines with water, requires carbonic anhydrase, forms carbonic acid, which dissociates into hydrogen ion and bicarbonate ion. Now this hydrogen ion will come into the lumen. अब lumen में already hydrogen ion का concentration बहुत ज़्यादा है. So what happens is that this hydrogen ion has to come into the lumen against a concentration gradient. Now when an ion is flowing against its concentration gradient, it will require energy. So energy would be derived from hydrolysis of ATP. ATP would be formed in the mitochondria. So parietal cells have a number of mitochondria within itself, right? So this hydrogen ion comes into the lumen by means of a hydrogen potassium ATPase pump. ठीक है, hydrogen potassium. This is counter transport against the concentration gradient. So what is happening? Requires energy coming from hydrolysis of ATP. So hydrogen potassium ATPase pump, right? So hydrogen comes into the lumen, potassium comes into the cell, Now this potassium which comes into the cell, you know that there are presence of potassium leak channels. So potassium already is high in the cell, in the intracellular compartment. So the potassium diffuses through the potassium leak channels. Then this gradient is also being maintained by the operation of sodium potassium ATPase pump, which is acting on the basolateral side of the membrane. ठीक है, अब क्या हुआ, जो कार्बोनिक एसिड हाइड्रोजन आयन और बाइकार्बोनेट में डिसोसिएट किया, तो वो जो बाइकार्बोनेट है वो बेसोलैटरल साइड से ये यहाँ पे चला जाएगा इंटरस्टिशियल फ्लूइड में और फिर वो ब्लड में चला जाएगा. ठीक है, सो ये क्या किससे जा रहा है, ये जा रहा है बाइकार्बोनेट क्लोराइड एक्सचेंजर से, राइट. सो बाइकार्बोनेट गोज इनटू द ब्लड स्ट्रीम and chloride moves into the parietal cell, and now this chloride, what is happening is it comes out through the chloride channel. So here you can see there is movement of chloride ions into the lumen. हाइड्रोजन आ गया, क्लोराइड आ गया, दोनों कंबाइन करके HCl बना देंगे, right? So HCl secretion will occur. So this was the mechanism. Now I'll give you some of the notes. A specialized tubulo-vesicular structure is present in the parietal cell. In the basal state, I've already told the rate of secretion is low. When it is stimulated to secrete the HCl, then what will happen, that these membranes will fuse with the plasma membrane and cause increase in the number of pumping sites at the surface of secretory canaliculi and increase in the apical membrane area which is secreting acid. तो ये आपको एक resting cell दिखा रहा है parietal cell में. This is a resting cell. You can see that there are tubulovesicular structures which are present in the cytoplasm, and these tubulovesicular structures, they have the hydrogen potassium ATPase, which is a key player in the secretion of HCl, right? So hydrogen potassium ATPase is also known as a proton pump. क्योंकि ये hydrogen ion is a proton, so it is also known as a proton pump, right? अब इस resting cell को जब स्टिमुलेशन मिला, स्टिमुलेशन किससे मिला, इसके 3 एगोनिस्ट होते हैं, मेन 3 एगोनिस्ट है. एक तो एसिटाइल कोलिन है जो मस्करानिक रिसेप्टर के थ्रू एक्ट करेगा, दूसरा हिस्टामीन है जो H2 receptor के through act करेगा, third which is not shown here is the gastrin which will act through the gastrin receptor. So when it is stimulated by any of these or all 3 of them, what will happen, that these tubulovesicular structures, they insert themselves into the canalicular membrane. Now this is the activated cell. When the activation occurs, so these structures, they come onto the apical side and they fuse with this. So they have increased the number of proton pumps which are available for secretion of hydrochloric acid or for secretion of hydrogen ions, right? So on stimulation, there would be a rearrangement which causes the tubulovesicular membranes to fuse into the canalicular membranes. Okay. अब ये, it is just showing you a repetition of what I have already described you. So this is the first step. Carbon dioxide combines with water in the presence of carbonic anhydrase in the parietal cell to form carbonic acid, dissociates into hydrogen and bicarbonate. It comes out into the lumen by proton pump, and this is your hydrogen potassium ATPase pump. Bicarbonate comes into the bloodstream by by bicarbonate chloride antiporter, and because this is an alkaline in nature, bicarbonate, so this is known as the alkaline tide. When you eat food, the venous blood pH may increase slightly, and this is known as the postprandial alkaline tide. Again, important short note, or you can just get it as a part of your long question. What is the cause for postprandial alkaline tide? Right? So here you can see that the pumping action, hydrogen comes out, bicarbonate goes into the bloodstream. This is known as the postprandial alkaline tide. The chloride which is coming here combines with the hydrogen ions to form HCl. Key player is your hydrogen potassium ATPase pump or the proton pump. So there are drugs which have been developed to act against this proton pump, and they help in controlling the acidity which occurs. So in this patient which I started my lecture with, she was given omeprazole, and omeprazole is a proton pump inhibitor. So this is the key steps in the formation of acid secretion. It is extrusion of hydrogen into the lumen in exchange for potassium ion. Potassium ion is taken up into the parietal cells, recycled through potassium channels. Final component is passive movement of chloride into the lumen. Net result is secretion of HCl. This I have already told you. All these things. Hydrogen is the substrate for this. Bicarbonate exits through the exchanger, and this can help in maintaining the regulation of the pH. Right? Hydrogen is pumped against a concentration gradient. Lumen of stomach is electronegative. Chloride enters the gastric lumen against the electrical and chemical gradient both. Energy is required for both of these, derived from ATP, right? So another question is, why does the secreted acid not diffuse back into the gastric mucosa? Now this again I told you, in the gastric mucosal barrier, it is preventing the back leak of hydrogen ions which was secreted, right? So there should be a minimal back leak into the mucosa of the secreted acid in order to produce a high concentration of hydrogen ions within the gastric lumen, and a major part of this is coming through the gastric barrier, which is due to the formation of the alkaline mucus and because of the presence of tight junctions between the epithelial cells. If this barrier is damaged by toxic substances such as occurs with excessive use of aspirin or alcohol, the secreted acid does leak down an electrochemical gradient into the mucosa, causing damage to the mucosa of the stomach. Right? Again, another question, why does the pH of systemic venous blood rise after a meal? I have again told you, it is because the bicarbonate is entering inside into the venous blood. This is called as postprandial alkaline tide, and it is characterized by alkaline urine and slightly depressed breathing. Right? Now we come on to another important part of it, is the regulation of HCl secretion. Right? तो पहले आपको ये हो गया कि glands कौन से हैं, फिर गैस्ट्रिक जूस क्या होता है, फिर उसके कंपोनेंट्स क्या है, उसके बाद HCl का सिक्रीशन कैसे हो रहा है, pepsinogen I have also told you. I have also told you a little bit about the mucus secretion. Then we come on to how the secretion of HCl is occurring, how the control of HCl secretion is occurring, right? So when the stomach has been empty for several hours, that is your basal acid output, after a meal, the stomach promptly increases the rate of acid secretion. Now, there are three major mechanisms by which the regulation of HCl secretion occurs. So these are known as the physiological agonists, right? So this is showing you a parietal cell. In the parietal cell, you can see that there is presence of receptors on the parietal cell membrane. You have presence of H2 receptor, muscarinic receptor, and you have the presence of gastrin receptor. So acetylcholine is a neural mechanism, histamine is by paracrine mechanism, and gastrin is by endocrine mechanism, right? So you can see that in the regulation of HCl secretion, all these three mechanisms are playing a role, the neural, the paracrine, and the endocrine mechanism. Another thing which you can see here is that the acetylcholine and the gastrin, both of them are acting by increasing the intracellular calcium ions. And once the intracellular calcium ions are increased, they cause the activation of protein kinase C, which in turn causes the insertion of the hydrogen potassium ATPase pumps uh, into the parietal cell membrane, right? So जब आप regulation में HCl secretion के क्या है कि हमको what is to be done is basically that there has to be a rearrangement of the tubulovesicular membrane or the tubulovesicular structures which contain hydrogen potassium ATPase pump. और ये arrangement कैसे होगा? ये arrangement intracellular calcium increase से होगा. Intracellular calcium increase कैसे करेगा? Either there is the release of acetylcholine, which occurs by the stimulation of the parasympathetic nervous system, or it can occur because of the release of gastrin from the G cells, which are present in the antral glands or the pyloric glands, and they cause insertion and increase in HCl secretion. Another mechanism is by the histamine, which is released by the enterochromaffin-like cells. So it acts through the H2 receptor, and in this the molecular mechanism is basically activation of the adenyl cyclase enzyme, which causes increase in the cyclic AMP, and this in turn again causes activation of protein kinase C, which causes insertion of hydrogen potassium ATPase pump. ठीक है, इनको सबको आप inhibit भी कर सकते हो. So there are certain endogenous antagonists which are present in our body. Endogenous means which is present within our body. So you have the presence of somatostatin, prostaglandin E, and you have epidermal growth factor and transforming growth factors. All these are acting through inhibition of the adenyl cyclase enzyme. ठीक है, तो रेगुलेशन में agonists हो गए और antagonists हो गए. Agonists में you have acetylcholine, histamine, gastrin. Histamine is the most potent stimulator of gastric acid secretion. Okay. Then we have presence of endogenous antagonists in the form of somatostatin, which is released from the D cells. Then you have prostaglandins and presence of epidermal and transforming growth factors, which again act by inhibiting the enzyme adenyl cyclase. Okay. अब हर एक के लिए drugs भी develop हो गई है. So you have antihistaminic drugs which are acting through H2 block receptors. So you have drugs like ranitidine, cimetidine. These are basically H2 blocker drugs. तो रश्मि ने क्या लिया था? Rantac tablet लेती थी जिससे उसको relief होता था. So it is acting by inhibiting the H2 receptor by competitive inhibition. Then the anticholinergic drugs can also help in reducing the gastric acid secretion. So these are basically the pirenzepine is one of the anticholinergic drug, and the gastrin secretion can also be inhibited, or you can cause the inhibition of proton pumps. So these are the proton pump inhibitors are the preferred drugs which are given these days. This I again give you when I'm telling you about the treatment of peptic ulcer, right? So acetylcholine is neural, gastrin would be released into the bloodstream and will reach the parietal cell. So it is acting via the endocrine mechanism, and histamine is a paracrine, is acting via the paracrine mechanism. Again, important MCQ, the strongest agonist is histamine for gastric acid secretion. So this is showing you in the regulation of gastric acid secretion or the gastric secretion, you know, three mechanisms. One is neural, endocrine, and paracrine. So in the neural, it is by means of the vagus nerve. Vagal activation will stimulate multiple cell responses via the neurotransmitter. It will act through directly, and it can also act through the enteric nervous system. तो ये क्या करेगा वेगस का? ये पेप्सिनोजिन का सिक्रीशन बढ़ाएगा from the chief cell, HCl secretion from the parietal cell, and it will also cause the release of histamine from the enterochromaffin-like cell. In addition to this, it also causes the release of gastrin from the G cell. But here, these three are mediated by acetylcholine, release of acetylcholine, and gastrin secretion occurs by the neurotransmitter gastrin releasing polypeptide. Okay. So vagal stimulation increases HCl secretion in two ways. One is directly, it acts on the parietal cell to cause the release of HCl. Another is indirectly by paracrine and endocrine mechanism. Okay. इनडायरेक्टली कैसे, इसने कॉज करा एंट्रोक्रोमैफिन लाइक सेल को स्टिमुलेट करा, उसने क्या रिलीज करा, हिस्टामिन रिलीज करा. कहाँ रिलीज करा, ये इसमें इंटरस्टिशियल फ्लूइड में रिलीज करा, जहां से ये पैराक्रीन मैकेनिज्म से पैराइटल सेल पे एक्ट करेगा. दूसरा है इसने जी सेल को स्टिमुलेट करा, जिसने गैस्ट्रिन रिलीज करा. वो कहाँ गया, ब्लड स्ट्रीम में गया, ब्लड स्ट्रीम से वो पैराइटल सेल में पहुंचा और उसने HCl secretion बढ़ाया. So vagal stimulation increases HCl secretion directly and indirectly. So regulation of gastrin secretion, तो पहला आपका ये न्यूरल मैकेनिज्म हो गया, दूसरा अब आ रहा है गैस्ट्रिन मैकेनिज्म, राइट. तो गैस्ट्रिन ने क्या करा, ये वेगस ने क्या करा, उसने एक्टिवेट करा जी सेल को. जी सेल कहाँ प्रेजेंट है, जी सेल इज प्रेजेंट इन द पाइलोरिक ग्लैंड. यहाँ पे इसने कैसे स्टिमुलेट करा बाय रिलीजिंग गैस्ट्रिन रिलीजिंग पॉलीपेप्टाइड. तो अगर आप इसको एट्रोपिन दोगे तो एट्रोपिन से ये ब्लॉक नहीं होगा. दैट proves that it is not the acetylcholine which is released here which causes the activation of G cell, but it is by means of the GRP, right. गैस्ट्रिन का स्टिमुलेशन और कैसे बढ़ता है, बाय मींस ऑफ प्रोडक्ट्स ऑफ प्रोटीन डाइजेशन, दैट इज पेप्टाइड्स एंड अमीनो एसिड्स इन द ल्यूमन. Gastrin secretion is not blocked by atropine. I have given you the reason why. Okay. Gastrin secretion is inhibited by somatostatin. Somatostatin is released by D cells. So whenever the pH of the lumen goes below 3, along with that somatostatin secretion also increases, and this in turn it's going to cause a decrease in the secretion of gastrin. So this is basically acting in a negative feedback manner. So this is a summary of the role of vagus in gastric acid secretion. The vagus nerve acts on directly on the parietal cell to increase secretion, through enterochromaffin cell to cause release of histamine, which causes stimulation. Now you can see histamine is the most potent stimulator for gastric acid secretion. Then it acts on G cell to cause release of gastrin, which stimulates HCl secretion. It also it is inhibiting the D cell, which causes the secretion of somatostatin, right? So the vagus is inhibiting the secretion of D cell. The secretion of D cell would be increased by gastrin itself, or it would be also increased by the acidity of the lumen. So all these three, they help each other and they potentiate the effect of each other. So it is known as the multiplicative effect of secretagogues. The secretagogues is the one which is causing a increase in the secretion. So acetylcholine, histamine, gastrin, they potentiate the effect of each other on the parietal cell. Histamine potentiates effects of gastrin and acetylcholine. H2 blockers like cimetidine, they inhibit the secretory responses, right? Acetylcholine potentiates the effects of gastrin and atropine. So this is just showing you that how these three are, the physiological agonists are acting, right? Atropine attenuates secretory effects of histamine. However, it does not affect the gastrin secretion cue, because gastrin secretion is caused by the release of GRP. Now we come on to another important aspect of this, and that is the uh, phases of gastric juice secretion. So phases of gastric juice secretion, it occurs in 3 phases: cephalic phase, which is elicited before the food reaches the stomach; gastric, when the food is in the stomach; and intestinal, when the food goes into the chyme, enters the duodenum and the upper jejunum. Right? So these are the 3 phases of the gastric juice secretion. The cephalic phase is mainly mediated by the neural mechanisms, contributes 30% of the gastric secretion. 60% of the gastric secretion occurs in the gastric phase and 10% occurs in the intestinal phase. Right? So this is the phases of gastric acid secretion. Here you can see that the sight of food, the smell of food, the thought of food, all these can lead to increase in the gastric secretion. So that is, although the food is not there, but still there is an increase in the gastric secretion. This is your cephalic phase. कैसे प्रूव कर सकते हो cephalic phase को? sham feeding के through. In this, what has been done is that the esophagus of this is a dog. Sham feeding was done in dogs. Sham feeding में क्या करा था कि esophagus of the dog was exposed. It was divided in the middle of neck, and then 2 cut ends were brought to the surface. ठीक? जब dog को खाना दिया, when the dog was swallowing food, so it was coming out through the cut end of the esophagus, right? So it is not entering the stomach, but still what happens is that when the dog is eating food and the food is not reaching the stomach, still you can see that the gastric secretion increases. So this is the cephalic phase of gastric secretion, which is elicited 5 to 7 minutes after a person or an animal starts eating, or even a thought or sight or smell of food can lead to the increase in gastric secretion. Second phase I told you is gastric phase of gastric acid secretion. There are 2 primary stimulus to that. One is the distension of the stomach by food, and second is presence of digestion, the protein digestion products, right? So those stimulus है इसके gastric phase के, जब खाना or when the food has reached the stomach, so it is going to cause distension of the stomach wall. Now this, the distension of the stomach wall will lead to stimulation of the stretch receptors via the vagus nerve. It will go to the dorsal motor nucleus of the vagus in the medulla, and from there the efferent neuron will arise. So this is your vagovagal reflex. जब भी reflex की बात करते हो तो क्या होता है? Reflex has a receptor, it has an afferent, it has an integration center, it has an efferent and an effector. तो vagovagal reflex, vagus से ही efferent component गया और vagus से ही efferent component आया. Afferent component कहाँ से गया? Stretch receptor of the vagus of the stomach. Afferent is the vagal fibers. The integrating center is the dorsal motor nucleus of the vagus. From there, the efferent neurons go to the effector. Effector क्या होगा? Effector होगा parietal cell होगा, effector होगा G cell होगा, effector होगा ये enterochromaffin like cell होगा. तो इन सब में क्या होगा? डायरेक्टली एक्ट कर रहा है parietal cell पे to secrete hydrogen, hydrochloric acid. Antral cell will cause release of gastrin. This gastrin will cause release of hydrochloric acid. Gastrin will also act on the enterochromaffin like cell, cause release of histamine, cause secretion of HCl. दूसरा है local enteric nervous system reflexes. तो अगर denervation भी कर दो, vagus काट भी दो, तब भी ये gastric phase होगा because of the enteric nervous system which is present within the walls of the GIT. Another stimulus is your digestion of protein product, that is peptides and amino acids. They act on the antral G cells to secrete gastrin, and again this will increase the secretion of HCl. So this is how the gastric phase of gastric acid secretion occurs, which has both the neural as well as the endocrine and the paracrine component. जो cephalic phase है वो primarily occur कर रहा है through the neural mechanisms. Third is your intestinal phase of gastric acid secretion. The protein digestion products, what they do is that they stimulate the intestinal G cells. So duodenum में intestinal G cells भी present होते हैं. These are the antral G cells, and they cause the release of HCl. Then these are lesser known substances which are present in the intestinal endocrine cells. So these are known as enterooxytocins, which also cause the release of HCl. And absorbed amino acids in turn also cause the release, but their mechanism is still not clear. Right? So this is giving you a summary of the phases of gastric secretion. The cephalic phase, sight, smell, taste, and thought of food, or even the emotions, they can cause the higher centers. It's coming through the higher centers, through emotions are through the amygdala. Then you have the appetite center in the hypothalamus. They act via the vagal nucleus in the medulla, and they cause the release of gastric secretion by these mechanisms. Gastric phase occurs by the distension of the stomach wall by the vagovagal and the enteric nervous system, or it can occur because of the presence of partially digested protein products. Intestinal phase, it can be through the enterogastric reflex because of the distension of the intestine, or there is presence of the protein background products. So this is just contributing 10% to the secretion of gastric acids. Right? So this is showing you the meal-related phases of gastric secretion and their regulation. This is a summary of what I have told you in the phases of gastric acid secretion. I am again and again reinforcing that because ये भी एक बहुत common question है. Enumerate the phases of gastric acid secretion and describe their mechanism and how they are regulated. Right? So this is giving you an overview of how the meal related changes occur in the gastric secretion and how they are regulated. So this is showing the effect of eating on gastric acid secretion. So here you can see this is the volume of the gastric juice, and what happens as soon as you ingest food, this is showing the time gap occurring after the ingestion of food. So as you ingest food, the volume of gastric secretion increases, and the rate of hydrogen ion secretion also increases. So as the hydrogen ion secretion increases, the pH is going to decrease. Right? As the stomach empties, what happens is जैसे जैसे stomach empty होगा वैसे वैसे जैसे जैसे the stomach is emptying, the rate of secretion of the gastric juice will the volume will start decreasing. So this is again a summary of the various mechanisms which operate for regulation of gastric juice secretion. Okay. So this is showing you again the summary of all the mechanisms which are operating. So you have the branches of vagus nerve. So branches of vagus nerve, they act directly. Acetylcholine will cause release of HCl from parietal cell. It will cause release of histamine from enterochromaffin-like cell, which again acts on parietal cell. Then you have G cells. In the G cells, you can see that this is going in both the directions. So gastrin causes release of somatostatin. Somatostatin in turn inhibits the gastrin secretion, and somatostatin release also causes a decrease in the HCl secretion. Okay. So this is from where we started. We started from the case of Rashmi Thakur, 50-year-old lawyer who presented with chief complaints of burning, gnawing, abdominal pain for the last few weeks. She got up in the middle of the night, pain in the upper middle abdominal region, relieved by eating food, recurs 2 to 3 hours after a meal, no relief in pain on taking ibuprofen, relieved on taking Rantac tablet. ठीक है, तो ये आप देख रहे हो कि ये सब क्यों हुआ. So now you can just correlate with all the knowledge of how the HCl is being secreted, how the mucus is helping in protecting the stomach mucosa from damage by secreted acid and pepsin, and why Rantac tablet led to a temporary relief in her symptoms. Right? So then we come on to peptic ulcers. So peptic ulcer is a part of your competency, I think 4.9, right? So I'm taking this with this only. I will not cover it. Whatever applied aspects I'll be covering with the topics itself. Okay. So what is a peptic ulcer? It is an excoriated area of stomach or intestinal mucosa, occurs when damaging effects of acid and pepsin overcome the ability of mucosa to protect itself. There can be two types of ulcers. You can have it as gastric ulcers or you can have it as duodenal ulcers. So in gastric ulcers, main problem is decreased ability of mucosa to protect itself. Duodenal ulcer, main problem is exposure to increased amounts of acid and pepsin. What are the causes and the risk factors for peptic ulcers? You have the gastric ulcers and you have the duodenal ulcers. So in the gastric, you have that these are also known as the stress ulcers, physiological stress, Cushing's ulcer, Curling's ulcer. So these are just giving you the causes of the predisposing factors of gastric and duodenal ulcers. Another difference which you can see here is that in the gastric ulcers, there is either normal or hyposecretion, and pain occurs half an hour to 1 hour after meals. Whereas in case of duodenal ulcers, it's usually 2 to 3 hours after meals. Right? These are the common causes. Now, commonest cause is the Helicobacter pylori infection. You have NSAIDs, the non-steroidal anti-inflammatory drugs like Voveron, ibuprofen. So all these, they cause damage to the mucosal membrane. Alcohol again is a predisposing cause to peptic ulcer, or it can run in families. There can be excess of stress, there can be hypercalcemia, or there can be Zollinger-Ellison syndrome, in which there is excess secretion of gastrin and which keeps on leading to HCl secretion. So whenever there is a disbalance between your defending factors and the aggravating factors, it leads to the production of gastric ulcer. So you can see that in the defending factors, you have the gastric mucosal membrane or the the diffusion barrier which was present, which helps in defending against the auto digestion. And these are the predisposing factors for the aggressive factors for causing peptic ulcer. Why does it occur? What is the pathophysiology? Now it is easier to explain. In the normal case, what happens is that this is showing you an intact gastric mucosal barrier. There is secretion of the visible or the insoluble mucus from the surface epithelial cells. Then there is secretion of bicarbonate ions. This maintains an alkaline pH in the adjoining areas. Then there are presence of the tight junctions, the prostaglandins. All these are helping in protecting the gastric mucosal barrier and from auto digestion. When one or more of these factors are deranged, then this mucosa starts getting infiltrated. There can be a bacterial infection, there can be a lesser blood supply, then it can lead to damage to this mucosa, and now what happens is ulcer formation occurs. Right? So these are the two physiologists, you could say, or scientists, you can say, who got the Nobel Prize in Physiology or Medicine in 2005 for their discovery of the bacterium Helicobacter pylori and its role in gastritis and peptic ulcer. ठीक है, तो जो आप लोग quizzes में जाते रहते हो ना, you could be asked a question on who was awarded the Nobel Prize in Physiology or Medicine in the year 2005, or for what, or who were the two scientists. Okay. And it is an interesting trivia that Dr. Barry J. Marshall, who was awarded this Nobel Prize, what he actually did was, he, since it was illegal to test his theory on humans, he drank the bacteria himself. The bacteria मतलब जो उसने aspirate करा था patient से, वो खुद उसने खा लिया, and he got infected, he got the same symptoms. So before the discovery of this Helicobacter pylori infection, usually they were considered to be stress ulcers, but now the latest concept is that 70 to 80% of cases of peptic ulcer are caused by this infection. Right? So this is the pathophysiology of how the Helicobacter pylori causes the mucosal damage. Now this Helicobacter pylori infects the lower part of the stomach, and once it is there, it causes an inflammatory response to occur. Once there is an inflammatory response which is occurring, inflammatory means वहाँ पर inflammation occurs because of the phagocytosis, and you must have read in the blood about the various steps in phagocytosis, that there is the release of there is the margination, which is followed by the chemicals are going to attract it, so there would be margination, then there would be the diapedesis, and there would be accumulation of the immune cells there, namely the polymorphonuclear lymphocytes are going to aggregate and give rise to the redness. The redness and the tenderness would occur, and it can also lead to increase in the temperature, right? And when this goes on, when the ulcer forms, it can complicate in the form of a bleeding ulcer. And once the bleeding occurs, then the patient may start vomiting out blood, along with the vomit, the blood may also start coming out. So that is known as hematemesis, or that blood can go into the stools and can produce the tarry brown stools. They are known as, that is known as melena. Okay. So this is just showing the pathophysiology. Normal mucosa infection हुआ तो पहले inflammation होगा, फिर उसके बाद atrophy होगी, metaplasia, dysplasia, cancer. These this ulceration can also lead to the gastric carcinoma. And if you remember, in the case I told you about, the urea breath test was positive. So that this is basically the breath test which is done for confirmation of the Helicobacter pylori infection, in which what is done is basically that the patient is asked to drink a solution of the radioactive carbon enriched urea, and then 30 minutes later the patient exhales into a collection bag, right? So first the patient is made to drink a solution which is enriched with this 13 carbon, and then after that it the patient is asked to exhale, and in the breath, once the breath is collected into a bag, you can see here is a bag, then it is subjected to a fluid is added into it, and then it is subjected to spectrometer reading, where the confirmation occurs that yes, urease is present, and once the urease is present, it is confirmatory for Helicobacter pylori infection. So I'll just show you a video of
You can find written notes on this topic at zerotofinals.com/peptic ulcers or in the gastroenterology section of the Zero to Finals Medicines book. Let's jump straight in. Peptic ulcers involve ulceration of the mucosa of the stomach, which we call a gastric ulcer, or of the duodenum, which we call a duodenal ulcer. And duodenal ulcers are more common. Normally there's a protective layer in the stomach which is comprised of mucus and bicarbonate, which neutralizes the acid, and this is secreted by the stomach mucosa. And this protective layer can be broken down by medications, such as steroids or non-steroidal anti-inflammatories like ibuprofen or naproxen, and a bacteria called Helicobacter pylori. There can also be an increase in stomach acid, which makes the stomach mucosa more prone to ulceration. And increased acid can be caused by stress, alcohol, excessive caffeine consumption, so too much tea and coffee, smoking, and spicy foods. So how do patients with peptic ulcers present? Well, a typical symptom is epigastric discomfort or pain, and they might have some tenderness to palpation in that area. They can have nausea and vomiting, dyspepsia, so all of the symptoms associated with indigestion. If they start bleeding from that ulcer, it can cause hematemesis, which is vomiting up blood, or it can cause coffee ground vomit. And coffee ground vomit is digested blood that's vomited out of the stomach. And also melena, which is tarry black stools caused by digested blood as it passes through the GI tract. If they have constant low-level bleeding from a gastric ulcer, this can cause an iron deficiency anemia. And this is quite a common presentation of a gastric ulcer or a gastric cancer, is to check somebody's bloods and incidentally find an iron deficiency anemia. A little tom tip for you, in your MCQ exams, eating typically worsens the pain of a gastric ulcer,
So yeah, it's
and
giving you a
eating
tip
improves
also.
the pain of duodenal ulcers. This is a typical exam question. And the way that you can remember this is as food passes into the stomach, it's going to irritate that ulcer, but food passing into the stomach will mop up some acid that then won't pass through into the duodenum, so it'll improve the duodenal ulcer pain. How do you manage gastric ulcers? Well, peptic ulcers need to be diagnosed first, and we do this with an endoscopy, so a camera test through the esophagus into the stomach and duodenum. During the endoscopy, they can do a rapid urease test, which is called a CLO test, and this can be performed to check for H. pylori. They'll also consider doing a biopsy during the endoscopy to exclude any cancer in that ulcer, as gastric cancer can look and present very similarly to a gastric ulcer. Then there's medical management, which is very similar to gastroesophageal reflux disease, using high-dose proton pump inhibitors to reduce the amount of acid in the stomach. And endoscopy can be used to monitor the ulcer to ensure that it heals and to assess for the development of further ulcers. There's a few complications from peptic ulcers. The first is bleeding from an ulcer, and this is relatively common. It can either be low-level bleeding that leads to a chronic iron deficiency anemia, or potentially it could be a life-threatening large hemorrhage, so it could potentially be quite a serious complication. The next complication is perforation, and this is where the ulcer creates a hole in the stomach, and fluid from the stomach can leak out into the peritoneum, and this causes peritonitis and an acute abdomen. This is an emergency and requires urgent surgical repair, usually laparoscopic or by keyhole surgery. And the final complication we're going to talk about is scarring and strictures of the stomach and the mucosa. So as that ulcer heals, it turns into scar tissue. And this can lead to narrowing of the pylorus, which is the exit of the stomach, and cause difficulty in emptying the stomach into the duodenum. And this is known as pyloric stenosis. And this typically presents with upper abdominal pain, particularly distension, nausea and vomiting, reflux. And these symptoms particularly come on after eating some food because that food can't drain out of the stomach. So thanks for watching. I hope you found this video helpful. If you did, don't forget there's plenty of other resources on the Zero to Finals website,
Okay, so by now you must be familiar with the duodenal and gastric ulcer. So both these are types of peptic ulcer. So gastric occurs in the stomach, duodenum it occurs in the duodenum, and epigastric pain usually occurs in gastric ulcer after eating, whereas it comes on in case of duodenal ulcer 2 to 5 hours after eating, and it is relieved by eating something. Okay. So this can cause hematemesis or melena, both of them can cause that. And it in the duodenal ulcer, it awakens the patient during the night. So now coming on to the medical management of peptic ulcer, again, this is important because this can come as a long question in the form of a problem, and in which you would be required to make a diagnosis, and then pathophysiology can be asked about it, and then it can also be that give the physiological basis of treatment in this patient, right? So the physiological basis of treatment in peptic ulcer would depend upon the regulation of your HCl secretion. So you have drugs which can inhibit gastric acid secretion. There are drugs which can neutralize the gastric acid, or there are ulcer protective drugs, or they can be anti-Helicobacter pylori drugs, right? So this is the by and large the broad classification of the peptic ulcer drugs. So you're familiar with this now. Reduction, the drugs which cause reduction in gastric acid secretion, they can be antihistaminics. Now in this antihistaminics, you have to remember that the antihistaminic should act through H2 receptor. Okay, so these are antihistaminic drugs which act through H2 receptor, which is present on the parietal cell by competitive inhibition. And the names of the common drugs are cimetidine, ranitidine, famotidine, roxetidine. So these are commonly available drugs which are used for treatment or management of peptic ulcer. Another category of drug which is more commonly used these days is proton pump inhibitors, which act by inhibiting the hydrogen potassium ATPase pump, and these are the drugs which, जैसे आपने OSID सुना होगा, so OSID is basically omeprazole, then you have lansoprazole, pantoprazole, rabiprazole. So all these are proton pump inhibitors. Anticholinergic drugs like pirenzepine, I have already told you. Prostaglandin analog, this can basically come as an MCQ, right? So misoprostol ये आपको सब pharma में ज़्यादा पढ़ाया जाएगा. Antacids are basically acting by neutralizing the gastric acid, right? So these are the antacids which are available, and Helicobacter pylori infection is treated by these antibiotics. Okay. So another, this is the last part which is remaining, is gastric function test. So gastric function test has been added in your new curriculum. So I have to cover this. Gastric function tests, what are they? They are basically done to assess the function of the stomach. And what are the indications for doing gastric function tests is to basically diagnose gastric ulcers, to exclude the pernicious anemia, and peptic ulcer in patients with gastric ulcer, or you could say gastric ulcer disease, for presumptive diagnosis of Zollinger-Ellison syndrome, which is apidoma type, so it's secreting the gastrin, to determine the completeness of surgical vagotomy. अगर कुछ chronic cases में vagal नर्व को कट किया जाता है, that is known as vagotomy, तो उसमें देखने को कि how effective that surgical treatment has been in that particular subject. So this is giving you a classification of gastric function test, analysis of the resting contents, that is in the interdigestive phase or in the fasting state. Then you have the fractional gastric analysis test, which is done using a test meal, that is known as the fractional test meal. Or you can assess the gastric functions by stimulating it, which can be stimulation by histamine, pentagastrin, or insulin, or you can also test for other gastric secretory products depending upon the chief complaints of the subject. Then the test for occult blood and Helicobacter pylori. Now, I have already told you about Helicobacter pylori, in which the urease breath test was done. Imaging techniques, plain radiography, barium meal, endoscopy. Now, in this, with the development of endoscopic techniques, more and more endoscopy is being done instead of the plain X-ray and barium meal. And of course, if the doctor suspects a gastric carcinoma, then you can go in for a biopsy. So this is the analysis of the resting gastric contents. कैसे analyze करते हैं उसमें you ask the subject to overnight fast. You must have not eaten anything in the morning, and then the gastric contents are aspirated एक tube डाल के either through the nose or the throat. The contents of the stomach are aspirated or taken out, and they are analyzed. So its volume should not be more than 30 to 50 milliliters after a night fast. If it is more, that means there is hypersecretion of gastric juice, or it can indicate retention due to delayed emptying. Pyloric stenosis हो सकता है तो emptying gastric contents की delayed है, या duodenal contents जो है regurgitate back कर रहे हैं, so there can be incompetency of the pyloric sphincter which can lead to regurgitation. So all these can lead to increase in the gastric contents after an overnight fast. Normally, it is a clear fluid which does not contain food residues, and if it is a bright red, brown, coffee ground, so it can indicate various disorders. Fractional test meal. Okay? So next is your fractional test meal. As the name suggests, fraction of a test meal, right? Previously it was used, but now since it's been included in your curriculum, so it can come as a short note. So fractional test meal, what does it mean? After an overnight fast, gastric fluid is aspirated, जैसे आपने इसका resting state का दिया, उसके बाद कोई भी standard test meal दी जाती है. Standard test meal क्या होगी? Either 300 ml of oatmeal gruel, or it could be a dry toast with a cup of tea, or it could be a wheat biscuit with 300 ml of water. Okay, you have a problem in your PBLs also. One of them is based on this test as far as I remember. Then after giving a standard test meal, the gastric contains 10 milliliters of fluid will be aspirated every 15 minutes for 3 hours. And then you analyze those gastric contents for each sample. Free acidity, total acidity is analyzed, and it is represented graphically. So this shows you a normal fractional test meal. This is A graph. A is showing you a normal graph that once you are doing a fractional test meal, then this is time after meal. So you can see that this is showing the acid output in gastric secretion. अगर ये increase हो जाएगा तो इसको hyperchlorhydria कहते हैं, which can occur in case of peptic ulcer disease. And अगर ये decrease हो जाएगा तो उसको hypochlorhydria कहते हैं, when there is a decreased secretion of the hydrochloric acid. So acid secretion in various conditions. Now this is just showing you a comparison. This is a tabular form. It is showing you acid output and serum gastrin are usually not diagnostic. Another thing which you can see here is that the serum gastrin levels are generally inversely related to gastric acid secretion, except in case of Zollinger-Ellison syndrome. Why? Because Zollinger-Ellison syndrome is a gastrinoma itself. Decreased acid output in gastric ulcer due to back leak through the damaged barrier. Right. Another test is the histamine test. It is comparatively more sensitive than the fractional test meal for studying the gastric acid secretion. It is because histamine is the most powerful stimulant of acid secretion. Secondly, due to histamine injection, acid level increases very rapidly and there is no time available for neutralization of acid. Procedure remains same after overnight fast. Morning stomach is aspirated, washed with distilled water, and then it is injected subcutaneously. 0.5 milligram of histamine is injected. Gastric samples are aspirated and analyzed just like fractional test meal. If there is no free acid present in any of the samples, it is called as achlorhydria or histamine fast achlorhydria. ठीक है, तो सबका बेस वही रहता है. Augmented histamine test, it is that you go on increasing the dose of histamine to see how much is the maximal secretory capacity of a person. That will give you the maximal acid output. It correlates well with the total number of parietal cells. Pentagastrin is also performed to assess the gastric acid status. Similar to histamine test, instead of histamine, here you give pentagastrin and again you aspirate the contents and see for the acid content of the stomach. Next is the insulin test. This is based on the fact that hypoglycemia, that is when the blood sugar level goes below 45 milligrams per, 45 below the level of 45, then what will happen is it will produce the stimulation of vagus and this in turn will cause secretion of acid from the stomach. So 7 units of insulin are given IV. Gastric samples are tested for presence of free acid. Acid secretion occurs after insulin injection only if the vagus is intact. So insulin test is performed after vagotomy operation to know whether all the fibers of nerve supplying the stomach have been cut or not. If vagotomy is done properly, insulin test should be negative. This is another test is your upper GI endoscopy. Started with this. So this is showing you the endoscopic photograph of a normal gastric antrum, and this is the insula angularis. Okay, so here again I have a video for you.
This is Dr. Joe Galati, and in this video clip, we're going to be talking about stomach ulcers. And in this illustration, you can see that the stomach is situated in the abdomen between the small intestine and the esophagus, nestled in next to the liver, the pancreas, and the gallbladder. Now, when we suspect ulcers, one of the first things that we would do, in addition to some blood work, is we would schedule an upper endoscopy. And this is an outpatient procedure where you'd come to the lab and a fiber optic flexible gastroscope would be inserted through the mouth into the esophagus, the stomach, and look at the small intestine. And through the instrument, which is very flexible, we're able to take samples and biopsies, take video and pictures of the ulcer to see just what is happening. Again, you're sedated for the procedure, so it's relatively comfortable. And in this video here, what you see is a young person that has an ulcer in the stomach, that deep crater right there in the stomach, right before the stomach empties into the small intestine. So this is in the antrum of the stomach, or very close to the pyloric channel. Many times you can bleed from ulcers. It can cause infections. It could perforate or break through the lining of the stomach and cause infections in the abdomen, and can be quite painful, especially on an empty stomach. There are medications available to treat the ulcer. Many times a bacteria called Helicobacter pylori is the culprit and would be treated with a combination of acid suppression medications as well as antibiotics. And so we've come a long way in diagnosing gastric ulcers and treating them, and in most cases they will heal. Of course, anytime you have abdominal pain, you really want to check out with your physician to be worked up further. If you have any questions, you could always.
Okay, so that is showing you how the endoscopic examination is done. So this is showing you the endoscopic picture of gastric ulcer. So here you can see these are the folds, the rugae which are present in the stomach, right? So if you just remember from the duodenal picture, duodenum doesn't have these rugae. And here what you can see, the arrows are showing you the presence of gastric ulcers, right? And this is a large penetrating gastric ulcer, so it is a bleeding gastric ulcer. And the last thing in this is the barium meal. So barium meal can be a single contrast or a double contrast. These are basically I've just put in pictures so that you can just get a hang of what barium meal exactly is. So a barium meal is given to a subject and then the x-rays are taken, and this is how the normal barium meal appears like. So this you can see is showing you the stomach, the normal stomach, the pylorus and the antrum, right? So this is a double contrast which is showing you the double contrast has been done here. And these are some of the abnormal barium meal pictures, which this here you can see is a pyloric stenosis, and then here is a duodenal ulcer which is visible, the crater. Then you have the gastritis. This is the erosive gastritis. Here there is carcinoma. This is a malignant gastric ulcer, and this is hiatus hernia when the stomach is going above the diaphragm. So that completes the gastric secretion, and any queries you can ask. Your CRs can collect the queries and they can send it to me and you can ask. Okay. So I hope the lecture was self-explanatory. Started off with the case, which was a duodenal ulcer case, and then I told you about how the gastric secretion is occurring, what is the mechanism, what are the phases, how it is regulated, and what is the management of peptic ulcer, what are the gastric function tests. Okay. Okay, so I think I'm in time, and any queries you can forward it to me. Thank you.